Looking at it, he's made much of his fame in talking about difficulty with fertility. But as cardiologists, most of us know and appreciate Sandy's work because he can tell us what the platelets are going to do and as we put various medications in. I noticed a talk of his today, he's going to tell us how the platelets really think. Sandy started out in Scotland. He got his initial degree from the University of Glasgow, and then he went and after doing that, he got it in the Department of Pathology and Laboratory Medicine at Emory. He came from Glasgow to here at Emory. And on the way, he had also gotten a fellowship done in both medicine and surgery at Glasgow Infirmary. And then he came here and he got his degree again at Mayo Clinic in clinical medicine and clinical pathology. So, Sandy, we appreciate you coming and educating us, and glad to have you. Thanks.
Good afternoon. Thank you for the opportunity to come and share my thoughts after a long time of dealing with coagulation issues, particularly platelets and the new DOACs. So we're going to talk about what those things do. Now, platelets are an interesting cell because they have no nucleus. So how can they possibly think? Well, they're a lot more interesting than you think, and I have no conflict of interest related to anything in this presentation. So what about a platelet? It's one of the most powerful and potent cells in the body. I call it small but mighty. That's its biblical connotation. It's involved in many disease processes. It helps keep our vascular tree healthy. It has an interesting range of normal counts. Why do those of us in this room have a platelet count that may be 3- or 4-fold difference from each other? Something we never really think about, but it's an interesting thing to look at. It's also the target for many drug effects, both useful and problematic. There are a lot of medications that have small impacts on platelet function that we don't think about. And ironically, impaired function is almost as important as low numbers for bleeding risk in a patient. So here is the thinking platelet. It has its antenna up looking to see what is going on. This is a platelet with a bad pseudopod day. Now you can imagine, for those of you who may have seen an E&M before, all these spindly things you see are a platelet being activated. It's normally a small 2-micron cell that does nothing very much. And when you put it in bad circumstances, it misbehaves by forming all these things and helping to form a fibrin clot. Now, physiologically, platelets get more diverse and interactive as time goes by. And the idea that they can be activated by a small number of pathways is no longer true. We used to think they were very simple little cells. Before I went to medical school, I was a medical technologist, and I worked in a lab, and platelets were simply a source of something called platelet factor 3, otherwise known as the platelet membrane. It's come a long way. Platelets actually secrete over 72 metabolically active compounds. They're involved in all kinds of things. However, our tools to evaluate and study their function in a clinical setting particularly are way behind what we've learned in the research area. There's lots of things I would like to buy for my lab that would help us look at platelets, but they're either expensive or not available in the United States. Now, this cartoon, as you can see, is both complex and perhaps not even legible, and I apologize for that. But this looks at the main platelet receptors on a platelet surface. Let's see if I can figure out how to do this without the... And you can see here, this is the thromboxane receptor, this is the thrombin receptor, or PAR1. These are the ADP receptors of particular interest to anybody in cardiology, P2Y12. This is the serotonin receptor. These are the platelet adhesion receptors. This here is the big gun. This is glycoprotein 2B3A. And however you activate a platelet, everything, as I will talk about, coalesces down here. So when you think about pharmacy for platelets or inhibiting platelets, please remember you're only inhibiting a small piece of its ability. And that's why, let me go back a second. All right, I did not mean that. Okay? Senile dementia is coming on. There we go. So again, one of the other things we've learned recently, there are actual genetic mutations in these receptors. So that's part of the problem, is not only are they there, but you can impact on them by having SNPs or various changes in the receptor themselves that either make them less or more active than not. And you can see again in this cartoon that here is the idea that platelets stick to the damaged endothelial membrane, and they also stick to each other. And this again is that important binding from glycoprotein 2B3A. So the multiple ways in which platelets can activate themselves confirms their role as a committed procoagulant cell. I'm doing something? Oh, okay. Right. Thank you. And that's important to remember. A platelet has no anticoagulant function whatsoever. Its job is to promote primary hemostasis and maintain primary hemostasis. And all the activation pathways we showed in these cartoons, thankfully, coalesce in one powerful action, which is to activate glycoprotein 2B3A, which binds to fibrinogen and sticks platelets together and forms a platelet clump. Now, as part of that, they also release multiple granules that have various functions, but all of which are supporting the formation of the primary hemostatic plug and preventing other parts of the coagulation cascade from breaking that clump down. Now, one of the roles of the clump, or the hemostatic plug, is to fix where the hole is and not extend up the vessels. So platelets are also involved in that, but in the interest of time, I'll move it along. So again, this is a sort of idea in the end what happens to the platelet. So it changes its shape, it sticks to damaged endothelium, it recruits its brothers in there and forms this tight, compact plug, which fibrin then forms around and is very difficult to get rid of. Now, some people in here are probably cardiology fellows. Why can't you get rid of a clot that's 24 hours old in somebody's coronary vessel? Because it's resistant. Fibrin is an incredibly tough biomaterial, and it's very difficult to dissolve once it's contracted down. So most of you are well aware the need for timing for either cardiac intervention or even more for strokes, because once that clot is there, once it firms up, it's very difficult to lyse. So, questions. Given the complexity of the platelet activity and its function, are there actually receptors that can be targets for inhibition therapy? And if so, what are the important ones? Platelets are not a socialist cell. They are where all functions are equal. And in true socialist fashion, some receptors are more important than others. The big guns are obviously the thromboxane inhibition, P2Y12, and PAR1. Now, all of these we'll discuss in some detail, but these are the targets that most of you will be available and will know something about. Now, here's the original and actually Nobel Prize-winning pathway that Simon Mankata got for figuring out that an aspirin would block cyclooxygenase. I guess, so this here. So when you activate a platelet membrane by phospholipids, it activates arachidonic acid. Arachidonic acid goes through cyclooxygenase to act on a bunch of intermediate prostaglandins whose names you do not need to know to generate thromboxane A2. Thromboxane A2 is a powerful vasoconstrictor and aggregating agent. So here's a platelet reinforcing its function. If you give an aspirin, you block this cyclooxygenase activity. That can also happen with Motrin or anything else. Now, please remember that when you inhibit the cyclooxygenase pathway, that platelet is then dysfunctional for the next 9 days. It is not a reversible process. The ADP receptor system is again very interesting. All these things are basically 7 transmembrane protein receptors. Here's the ones that we're interested in pharmacologically as P2Y12, and most of these have G-coupled protein activity. These are also have been and are targets for therapy. The new one is the PAR1 system, or PAR4, and this is a thrombin activatable one. Thrombin cleaves this little piece off here, cleaves this piece off here, and this loop actually folds together. So here was another independent target for pharmacy. So, and we talked about the idea of the big gun, so here they are. Thromboxane antagonists basically include aspirins. P2Y12 includes Plavix, Prasugal, Ticagrelor, and I guess to be complete, Cangrelor as well. The 2B3A antagonists are Tirofiban or Tirofiban, however you speak English, Riopro, and some mouthful called eptifibatide. And the only PAR1 antagonist that's made it through the FDA, and is the only one we'll have for a while, is Vorapaxar. Now, all of these function in entirely different ways, but the idea again is that how can I suppress or inhibit platelet function without causing any bleeding? So why are there so many drugs? Well, the aim of a good therapeutic drug is to be effective and minimize risk to the patient. So in antiplatelet therapy, the aim is to inhibit platelet function and minimize bleeding risk. Unfortunately, the more potent the antagonist, the higher the bleeding risk. And probably the worst examples are Riopro compared to aspirin. Riopro shuts everything down basically as soon as you give it, and then aspirin has a mild effect for a large number of days. So how do we assess the efficacy of therapy? All of you in this room prescribe various medications, and when it comes to looking at platelet inhibition therapy, most of the time we don't do anything. We give the drug and assume it works. Here's your 81 milligram aspirin. If I'm really concerned about you, I'll give you a 325 milligram aspirin. And that, most of the time, is the end of the story. If the patient doesn't occlude something or doesn't bleed, then we go, we did very well. It worked. If they occlude, then we give them more drug, or we add another one, for instance, dual antiplatelet therapy. If they bleed, we stop it or go to a lower dose. And if all else fails, occasionally we actually ask for help. So what is a role for monitoring? Does the laboratory have any role here? Now, how many of you in this room give a statin? Right. How do you know it works? How do you know a statin works? You get a lipid profile. And if the drug is working, what happens to the lipid profile is it improves. Hopefully cholesterol and LDL go down. That's exactly what the therapy is supposed to achieve. How many of you have prescribed an aspirin? How do you know the aspirin works? And the answer is you don't, because most of you and most people don't do anything. We assume after 100 years of therapeutic use that aspirins work. And they do, but they do not work in everybody. So, what choices, if any, do we have to look at functions of these drugs? For the NSAIDs particularly, we have the PFA 100 downstairs in the laboratory. This is a rapid 24/7 blood test for assessing NSAID function. It uses 2 cartridges. One includes epinephrine, and unfortunately, and despite what people think, it has no ability to consistently measure Plavix, so please don't ever do that. or any other P2Y12 drug. But it's a good assay. It works very well. The test was actually devised originally in Europe to find occult NSAID use in people going to surgery. Better still, and perhaps the gold standard, is something called Aspirin Works. This is a urinary assay for a platelet-specific analyte of thromboxane A2. Now, you may remember when I showed you the cartoon of the prostaglandin pathways, thromboxane A2 is one of the receptors. It's one of the products. It's very rapidly degraded to thromboxane B2, and we are able to measure a platelet-specific analyte for that. So for those of you who like pictures, this is a PFA 100. Very clever little machine. I actually saw the production line that makes the cartridge for this. It's an unbelievable piece of German engineering. Interestingly, when the machine was developed, it was thought that if you pushed blood through at a mean systolic pressure of about 100 millimeters, that would emulate blood pressure and the machine would read consistently, and it did not. Somebody thought if you suck it through, we'll see what happens, and it works reproducibly, and they still don't know why. It's the same pressure, but sucking this through the cartridge gives you reproducible results. Advantages, it's available 24/7. It only takes about 30 minutes to get done from the time you order it if you're lucky. If it's the middle of the night, it may take a bit longer. Unfortunately, like many of these platelet tests, it's influenced by the hematocrit in the sample. So you have an anemic patient, unfortunately, because this is a sort of viscosity-driven thing, the blood can sometimes go the whole way through and then it says, there's nothing to read. All machines have limitations. So, but nevertheless, on a routine basis, if you want a quick question, if I've given somebody aspirin and I want to know if it's working, this is the simplest way to do it. Now, the Aspirin Works is a more complicated issue. This is an ELISA assay. It is not rapid, but it's probably the gold standard for so-called potential aspirin resistance. It measures this analyte called 11-dehydrothromboxane B2, and this is truly specific for the suppression of thromboxane production by the cyclooxygenase inhibitors. So basically, this will tell you if you've given an aspirin, enough aspirin to achieve an endpoint. And the machine comes with a list of results that says if you're below 1,000, then you probably have good suppression of aspirin. Unfortunately, it's not easy to automate. It's never going to be rapid, but it's a very good test when you really want to know what's going on. Now let's move more significantly to the P2Y12 inhibitors. I'm sure as many of you know, I think Plavix still remains the biggest single revenue generating drug that we have. It's $1.5 billion a year in sales. Now, many of you here have given Plavix. You give a loading dose and then a maintenance dose. How do you know these work? How many of you have ever asked that question? I did the right thing. I loaded the patient. Dr. Morris raises his hand as I would expect. It doesn't always work. And the reality is for most of the time, again, we're back to looking for an adverse effect as our thing to say, gee, the drug didn't work very well. Why don't we give a bigger dose? Now, recently, the impact of pharmacogenomics comes into play. So one of the problems with Plavix is the body's system for metabolizing and deleting the liver is part of the CYP450 system. And in the case of all of the P2Y12 inhibitors, but particularly Plavix, there are 3 alleles that control how we metabolize the drug. The wild type is type 1, otherwise normal, and that's most of us. But the other 2 alleles, star 2 and star 3, show increased resistance to Plavix. And if you happen to unfortunately be a star 3 homozygous variant, then you literally have no response to Plavix at all. The failure to respond to Plavix can both delay or even cause treatment failures. So knowing if the drug is working, if you're going to load somebody particularly to do a procedure, it would be nice to know that it's safe to do so. All of the other P2Y12 inhibitors have an increased bleeding risk compared to Plavix. And ironically, just increasing the dose actually doesn't improve responses often, and it does not improve outcomes. So that's not the answer. So what is the answer? There's a test called Verify Now, which I'm sure some of you have heard. It's been used widely in many of the clinical studies, and it has a rapid turnaround, again, about 30, 40 minutes, and has defined cutoffs for therapeutic response. It uses a thing called a PRU, a platelet, I think it's refractory unit or something, and our platelet response unit. And we now have finally a cutoff of below 180 PRUs. Plavix is working. Above that, it is not. It's available 24/7 here, both at Emory and at Midtown, and it's quite useful. We actually get not a great deal of requests for it, so most of you are making the assumption that your Plavix works. This is what the toy looks like. So very simple. You just put blood in a special little cartridge, put it in the machine, and it will come out and tell you an answer. Now, this is designed only to tell you about suppression of the P2Y12 receptor. There's no other controlling thing. Now, let me introduce you to the word PIPA. Some of you in this room may have come across this. It stands for Platelet-Induced Platelet Aggregation. This is an optimized, focused platelet aggregation study that looks at the platelet responses to both ADP and aspirin using arachidonic acid as the aspirin antagonist. It's done on whole blood. It also includes the impact of red cells and plasma proteins. Now we used to do, traditionally we took platelets out of the blood and separated them and worked with those in the laboratory, and we can still do that. But that's not really what happens in us. Platelets are running around in a mixture of red cells, white cells, plasma proteins, and it'd be nice to know how those react. And we have used this for a long time here, initially and ongoing with our radiologists and others who put various large stents in people's brains, and they will not go to do this unless we tell them that it's all right. And we actually require an expert review to tell people that it's safe or not safe to do this. Now, this is probably hard to see, but this is what this actually looks like. The brown line is normal. So this is the patient's own platelets given a challenge by something called U46619. It's a thromboxane analog that will make the platelet respond normally. So when you see the brown line, that's the same response in a way compared to the green and the blue ones, which are aspirin ADP. So this platelet can work perfectly well if you give it the right challenge. But if you give it an ADP, which this now shows inhibition, it's a bit different. So we set our own benchmark. We actually ask the question, can these platelets work normally? And the answer is yes. And if I ask my question then, well, how do they react to ADP? The answer is poorly, because Plavix is inhibiting that. Here's a slightly cleaner version of the thing. You can see the brown line is very high and everything else is pretty much straight lined. That would be a totally acceptable response in this case to both aspirin and Plavix. So that's what we do often on a daily basis, and it's very useful, and we think it has a lot of benefits. Now the other question, this actually came up, I was called by a cardiology fellow about 3 months ago saying, why don't we do pharmacogenomics for Plavix? In other words, I'd like to know if somebody is a star 2 or star 3 allele, because if they are, I'm going to get a diminished response. And he said There's a thing called Spartan that measures this, and he's actually correct. This little thing, it's a small, but the size of an iPad, it's from a Canadian company, won the International Medical Thing of the Year in 2015. 30 minutes to get there, and you put blood in one end and out comes the pharmacogenomics on the other. The only problem is at the moment it's not through the FDA, and it only measures the STAR2 allele. If they measure STAR3, this would be perfect. But the cartridges alone are $250. So I told the cardiology fellow, unless he had some private benefactor, this wasn't likely to appear quickly on our lab. But this is clearly the way we're going. If you know or knew that information in advance, then it's going to stop you making a bad decision. Now, this is only about 10% of patients. But it's still 10%. If you're a STAR3 homozygous, it's a terrible thing to give you as Plavix because it's not going to work. Then there's going to be all these conversations about what to do, changing drugs. So there's a lot of implications, and I do think Spartan will get the STAR3 allele, and I think we'll see these things come into play in the next 3 or 4 years. You can do a standard PCR. We have occasionally sent them out, but it's cumbersome in the week or 10 days turnaround. It's not really what you want. PAR1 antagonists are perhaps the newest thing. They inhibit thrombin activation of PAR1. There's a modified, very unusual liquid chromatography mass spectrometry way to measure the drug effect. Not anything you're going to see in a clinical lab. You can measure thrombin inhibited platelet aggregation. Not an easy thing to do. It's not an agonist we work with here at all. And one of the problems with the drug is that it's a really long half-life. So, if any conclusions we can draw about single platelet therapy or dual platelet therapy of what? The drugs work. There's no question about that. But you cannot assume that they have predictable therapeutic effects. There are multiple impacts ranging from genomics to blood components to bioavailability interferences with how much impact they have therapeutically. Laboratory testing can help identify subtherapeutic responses, which in most cases is what you want to know, especially if you're going to do a procedure. And they obviously can improve the risk benefits of these widely used drugs. And I think some of them are available to you on a useful time frame. Because one of the critiques we get is, well, I sent it to the lab and about 2 days later the result came back. As a lab-based physician, I would be the first person to agree there isn't a lab test that you're going to make a clinical decision now that can be justified and useful in 2 days' time, with rare exceptions. So the idea of an occluded stent or a graft or a new stroke is not really an acceptable way to gauge the efficacy of dual antiplatelet therapy. Our experience in Emory Healthcare is if you use these laboratory tests for antiplatelet drugs, it really does minimize treatment failures. And we have used the PIPA very extensively here for, I think, 5+ years or more, with these people having pipeline stents with tremendous success. And if all else fails, you can give me a call and I'll try and answer some of your questions. At this juncture, does anybody have any questions about the platelet part of this? You're all comfortable that aspirin and Plavix works. Good. So let's move on to the DOACs, direct oral anticoagulants. They used to be transiently known as the NOACs, N standing for new or novel, until eventually we decided that it should all be called direct oral anticoagulants. These are clearly becoming the dominant form of short and long-term anticoagulation for both venous thromboembolic disease, particularly for AFib, for strokes, vascular grafts. They're very much on the ascendant use. Cardiologists seem to love Eliquis particularly. Doug, you're laughing at that. They have one specific mode of action, which is really nice. They inhibit coagulation factor 10, or in the case of Pradaxa, they inhibit thrombin. That's it. They don't do anything else. Coumadin, which many of us have struggled with for years, causes all kinds of side effects and complications. These drugs have very few side effects and almost no pharmacogenomic variation that we need to worry about. There are some caveats. Most of them have some degree of renal clearance, and that provides a limitation, but they all have very short half-lives. There's one of the new ones, I might as well go through there, which has almost no renal clearance at all, so you can use it in people even with renal compromise. The bleeding risk is lower than Coumadin, certainly in AFib. The equivalent risk in VTE, so there was not in the clinical trials a significant decrease in bleeding with the DOACs in VTE patients. That patients like these drugs. They like them better since the lawyers have got off of TV. How many of you saw all these adverts for, did you take dabigatran? Xarelto, call me. Because there's no food issues. This is the salve. People like greens. And so greens are full of vitamin K. And they're happy as can be that they can. I mean, it's very common here. If you talk to people in the Coumadin clinic, by midweek and Thursday, they're getting INRs in the 1.4 range because people went to the weekend and visited somebody and ate greens or kale. Do you remember when kale used to be left on everybody's plate? You go to a high-end restaurant, it was this little green thing and nobody ate it. And now it's like the wonder food. There's no alcohol limitations. People used to not drink on Coumadin. They told me I couldn't drink. It's not strictly true. But again, these are social benefits that patients will behave if you give them the right thing. And again, no routine monitoring is required. If you're a patient having to come to the Coumadin clinic once or twice a month and have dosage changes and everything else, costs both money and time. And in this case, dosing is actually very simple. There are 5 drugs available in the United States. Rivaroxaban, which is the first one we had, otherwise known as Xarelto, apixaban, beloved by our cardiology colleagues, and currently the market leader by a long way. Edoxaban, which ironically was the Japanese original drug that they had 10 years before anybody actually found out about it. It has a strange name called Cevesa. I've never seen anybody on it. It's not available in formulary here. Betrixaban is the newest one. Of course, it has all the pharmaceutical requirements of a drug with Y's and X's and Z's. It's called Bivixa. This is the latest or newest one out. It has significant advantages. It has almost no renal clearance whatsoever. So it's only about 5% renal clearance. So the idea that people with renal compromise, which is very common in our patient population here, this drug may have significant advantages. However, at the moment, my recollection is still only approved for people who are in hospital and transiting out for 30 days afterwards. And then the original problematic dabigatran. Dabigatran is the thrombin inhibitor. It was one of the first ones out on the market. This is the one that stimulated great interest by the lawyers because there were a lot of deaths, particularly in New Zealand, where as a national health system, they transitioned a lot of patients from Coumadin onto this drug and had a lot of deaths. Retrospectively, the company was forced to do an analysis, and of course it turned out that most of these people, as anticipated, had renal failure. So a lot of the stigmata for dabigatran has gone, but we see very little use for it, certainly in the Emory system. I have a couple of patients that take it, and they're happy with it, but that's fine. Ironically, given the fact that it appeared to have the highest risk of bleeding, it has the lowest risk of intracranial hemorrhage. So again, another enigma. So what are the limitations on the DOACs? Well, they're expensive. I had a patient this morning whine that it's $450 a month for her to take her Eliquis versus her $5 a month for Coumadin. These are issues that we as physicians don't necessarily think about very often, but for the patient, they're real. There was a lot of initial resistance from insurers to cover these medications. My second patient this morning, I'm actually in the middle of clinic, is somebody who I would like to get off because her INRs vary, but she doesn't think that Medicare covers it. And I thought that Medicare covered most drugs like this, but the answer was it depends which Medicare coverage you have. One of the other things I've learned is that many women who have normal menstrual cycles hate rivaroxaban. About 30% of them have a huge increase in menstrual bleeding, and they will tell you that very rapidly. I've had ladies say that I've had to wear a diaper for a month. So now, the good news is Eliquis does not do that. Again, since these drugs have almost identical modes of action, I have no idea why Eliquis seems to abrogate this bleeding or the menorrhagia completely, which it does. But that's the one downside of rivaroxaban. And in my own practice, I've actually stopped giving fertile women rivaroxaban. It also causes microscopic hematuria. When I had my hip replaced about 3 years ago, I put myself on 10 milligrams of Xarelto. And I kept wondering why my urine was kind of orange, but I was on various medications. And so after the 6 weeks, I stopped taking it, thankfully. And I got up to tinkle the next morning. I thought, oh, it's yellow again. Well, guess what? I had microscopic hematuria, so I tend to bleed pretty easily. Again, dabigatran causes a lot of GI effects. When we were trying to develop the assays in the lab, I took the drug and I didn't like it at all because it upset my tummy. A lot of patients complain about that, but as the routine 10A drugs have grabbed the market, it's not something patients complain about. And until recently, Pradaxa was the only drug that has a reversal agent. The one thing I can tell you from the advertising campaigns by our legal colleagues was that patients became very, very sensitized to the idea that the DOACs had no reversal agents. And in fact, I've had patients, and you may also have had the same experience, refuse to go on the drugs because they were concerned if anything happened in an accident, they were going to bleed to death. So where are we with these drugs? Well, lower doses of the drugs are actually proving effective. We've now begun to use 10 milligrams for long-term use for Xarelto, 2.5 milligrams for Eliquis, and there's evolving data that seems to work well. Recently, a drug-specific reversal agent was approved for the anti-10A DOACs. It's called andexanate alpha. It had a brilliant name called R-antidote when it was thought up, but unfortunately our colleagues in Washington didn't like that. So its unfortunate name is Andexa. This is a recombinant modified factor 10 analog. It binds to the drug, but it cannot be activated to factor 10A to promote coagulation. It's a brilliant piece of chemistry how these guys did this. They basically took the factor 10 molecule, chopped a piece of it off so that you couldn't activate anything, but the drug finds its binding site. I had a really good cartoon, but I couldn't get it to download properly. And now we come to the really important part. It's extremely expensive. It comes in 2 doses, depending on when you gave your DOAC. But if you have to use the full dose, it's $54,000 a dose. I can assure you this causes rectal apoplexy in our administration. So, what are we going to do about this drug? Well, it's ranged from let's not use it. We can muddle along with other things. However, the problem is it's the only FDA-approved drug for this use. And some smart lawyer is going to drag somebody into court and say, here you had a drug-specific thing approved by the FDA and you chose to use a cheap alternative. Why don't we just give it? That was actually a proposal. Or just give the drug, and that way we won't worry about it. So we actually, with our pharmacy colleagues, did a lot of work on this, and we found out that in the Emory system, which was mainly in this case Emory Hospital in St. Joe's, that in the previous 18 months there were 42 reversals for DOACs, which I actually was surprised about. My young colleague who was sitting here is the one that learned and informed me about that. So the financial impact of that is about $2.5 million. Now, I suspect pharmacy does not have enough padding in its system to suddenly absorb a $2.5 million cost. So there has been and there is ongoing discussion about how best to handle this. So one of the things is, should we use drug-specific blood levels? These are actually available in the special coag lab at EML, which is Emory Medical Labs, but only Monday through Friday, 9 to 5. So if you do have somebody and you want to know the level, we can do that. We just don't do it every single day, and we don't do it on weekends, because that's probably not necessary. So the question was, should we do that? When that was looked at, there was huge logistic and expenses about training staff at 5 hospitals, because I guess 6 now. That was decided as not a viable alternative. It would still take time to get to the routine lab. So, do we just make routine available drug levels at the core lab? So the answer was samples would be shipped to Emory. We would do the drug-specific level here. If you're dealing with a bleeding patient, that's not really a smart way to do. I'll just wait 2 hours or more to get a level. Now, I'm sure many of you have spent time at the other institutions, and sending something to between hospitals at 3 o'clock on a Sunday morning is not anybody's viable alternative to getting good information. So one of the questions that was raised was there any way to correlate a routine anti-10A assay to the drug level? And the reason that was raised is anybody, and you, probably those of you who don't work in a lab, all these drugs prolong the routine anti-10A level. So if you sent a heparin level on somebody on a Pixaban, it's going to come up at 2. We see this all the time, you don't. So that was a flag that was raised. Could we use that, and was there some way that we could get to a trough level, because the R level is known, which would indicate we didn't need to give the patient Andex, so we could either wait only a few more hours or not. Now, that being said, if the patient was bleeding, you're going to get the reversal agent. This wasn't an answer to say, I'm not going to give you this if you don't need it. But I would like to give you for the right reasons, not just because somebody came in with a small bleed or not. The irony is, if you happen to be into Bigatran, we have the reversal agent for that here. It's much cheaper. It's $4,000, but nobody uses Pradaxa. So one of the days, we looked at data here amongst our staff and with our pharmacy colleagues, which suggests that the routine anti-10 levels, so if you send down just a routine heparin assay or an anti-10A more correctly, ask the question, what's the number? Somewhere between 0.5 and 0.6 units on our routine anti-10A seems to fall very close to the trough levels for the drug, indicating we don't or may not need to give a dose. Now, this is still a work in progress, but surprisingly, it looks like it's holding up. We've done several hundred phosphorapixaban and closing in on rivaroxaban. And that may allow us to make a safe and smart decision and cost-effective decision about when or how much to treat the patient. So an overall conclusion, both anti-platelet and anticoagulation issues are challenging for clinicians. I've been doing this for 34 years and I still scratch my head. I've had an ongoing conversation with a neuroradiologist for the past 24 hours about how to solve a problem that none of us have a clear answer to. The balance between drug efficacy and bleeding risks are an ongoing debate. What do I use? What's the best drug? How do I know it's the best drug for this particular patient? Many of these drugs are used in elderly folks like me, and it's important to know bleeding risk increases. I'm sure all of you heard about the meta-analysis last week on the benefits or not of aspirin. So if you're over 80, the bleeding risk of aspirin exceeds the benefit of any cardiovascular effects. Combination therapies are often required, and these increase the bleeding risks. What is the best combination therapy? Nobody's exactly sure of that. We tend to go with the ones that we think are safer, but how do you know you're getting the correct efficacy? We don't. We in the laboratory can help you gauge, we think, appropriate therapeutic effects, as well as preventing supratherapeutic responses by increasing bleeding risk. That's it. I'll be happy to entertain any questions and let you get back to work.
I saw and been impressed that apixaban is so often used here, and I wonder if their marketing was better or they got hit the hardest, I think, initially by the attorney saying, call me if you have bleed or something, whether that worked to their benefit. But it is striking that one's so much more used than the others.
Yeah, I think the main driver for that was the AFib study that showed that apixaban had less bleeding than Coumadin, and that was a big one for the cardiac ward. Most hematologists still like rivaroxaban. It's once a day, and our pharmacy colleagues will tell us that that's still better than twice a day. But I think it was simply the fact that the trial said it's safer or less bleeding in an AFib population. And that's what seemed to drive that more than anything else.
The thing you said about menstrual bleeding with rivaroxaban is striking.
Oh, I got beat up with that like everybody else did.
There's questions out here.
That's the one there.
We're good at the other sites.
Dan?
Thanks a lot, Sandy. That was a great summary. So are there any patients or patient populations where you would, related to antiplatelet agents, where you're going to preemptively evaluate them, whether or not they're going to respond, or this is only in the situation where you find you give the patient some antiplatelet or multiple antiplatelets and they have an event with that, and then you check them? And if so, who are you actually checking and who are you not checking?
Well, I think that's a two-part question. I'll answer it by going backwards. When they started doing pipeline stents in neurosurgery here, one of the requirements was that the people had to be trained and signed off, and two, we had to have an ability to make sure that the aspirin Plavix regimen, which was standard, worked. But we didn't have that here, so we started doing full platelet aggregations. The first thing that we found out is an amazing number of these patients did not respond. And that was not our experience from the cardiac stent patients on Plavix, who seemed in general to do pretty well. It was very unexpected, and to this day we don't have any really good reason for this. We've looked at von Willebrand factors, we've looked at other inflammatory things, Pi1, factor 8, but that was completely unexpected in this population, and the question was the brain and brain-related issues are a mind of its own from a coagulation issue, but we didn't expect that, and we had not seen that elsewhere. So now these patients all get screened pre-procedure. So that's one way that when we saw a problem, the clinician said, we want to know that these drugs are working before we do anything in someone's brain. We don't see that to the same extent in other areas. That being said, we don't get a lot of PIPAs on cardiac patients. I think most of the time people use Verify now, if they use anything at all. I think it's underused. I think we've all grown up with the idea that aspirin works. We've had it since we were little kids. You got a fever, you got aspirin. But I think in the anti-platelet world, it's not as effective as we think. So I think there is a place for screening certain populations.
These drugs are not approved for valvular heart prosthetic valves. Is there a reason for that, or just they hadn't tested it yet?
They haven't tested enough of them. I think I've had quite a few patients. In fact, 4 years ago, I had somebody who had a mechanical valve and was put on dabigatran by his cardiologist in Idaho Falls, Idaho, and has done fine the whole time. I think it's just a matter there's not enough patients to get a clinical trial. There's no reason why they would not work that I can think of intellectually.
That's, I think, an important thing.
Andy?
There's a similar question piggybacking on that out of Grady. Just elaborating, other than patients on mechanical valves, anyone else that it seems shouldn't be on DOACs?
That needs to be on DOACs?
That should not be.
Obviously, renal compromise is the challenge. We do see, and somewhere about 2.5 creatinine, and about 2.5 seems to be an important marker. However, Betrixaban may answer that problem because it doesn't have almost any, or that's terrible syntax, it has almost no renal impairment at all. So I think that the drugs, if we choose the right drug, will solve many of the issues that we have.
So, Sandy, we live in a world of evidence-based medicine, but often where the evidence doesn't apply to the patient that we're seeing in front of us. So we have studies related to chronic coronary atherosclerosis where you should give aspirin. We see older patients who have atrial fibrillation, have had coronary disease. We don't have a lot of data, minimal data in patients over age 80, and certainly using combination therapy. And then we see these patients who come in and they're bruised. They show us their arms, they're bruised. And that type of situation, how do we use that information into whether we're giving patients too much of these drugs?
Well, I can tell you my bias is I think we don't need a daily aspirin in older people. I mean, I'm over 70 myself. I can't take aspirin. It gives me nosebleeds. So I've solved my own issue. But I think that going to and I see quite a lot of people with extensive bruising, and you're right, it's horrendous, and it's very both embarrassing and frustrating for the patient. Now, we need to get them to stop taking fish oil and vitamin E and some of the other potent things that people take. I think you can go for aspirin sometimes to every third day, and if you use the Aspirin Works assay, they'll stay below the magic 1,000. I think we've been used to traditional dosing of you take your drug every day, and I don't think that's necessary if we use this kind of laboratory to say, well, every second day and 81 milligrams of aspirin for you. It definitely cuts down on the bruising in the older patient. I've seen this consistently. And again, making sure that they're not taking herbal teas or other strange potions and lotions that they learn about at church on a Sunday.
Well, thank you. Appreciate it.
Okay, thanks very much indeed.